And let me share my screen with you. So are you able to see this PowerPoint?
Yes.
Okay. Some health promotion items, nutrition, weight, physical activity. We're going to talk about that more in geriatrics, especially in geriatrics. Low back pain is a very common health problem in the United States, and these are the factors that are associated with poor outcomes. Osteoporosis. Risk factors for osteoporosis are very important. And we have some risk factors that are not avoidable, like postmenopausal status in women, age more than 50. And we have some clinical conditions that we can do something about, like proper treatment of these clinical conditions. And we have a lot of medications that can also accelerate the process of osteoporosis. And if possible, we can avoid such medications. So please study this slide carefully. And the screening for osteoporosis, as you all know, is by the DEXA scanning, and less than minus 2.5, this is diagnostic of osteoporosis. Between -1 and -2.5, or -1 and -2.5, that's osteopenia, which is just kind of weakness that precedes osteoporosis. And there is a calculator of the fracture risk assessment, the FRAX calculator suggested by the WHO, by which you can assess future risk of fractures in patients with osteoporosis. Treating osteoporosis, you might refer to the PHARM course. Now let's talk about the history when it comes, the most common complaints when it comes to the musculoskeletal system. Musculoskeletal system includes joints, muscles, bones, trauma, injuries. So for joint symptoms, you need to ask about what's the character of this symptom. Is it stiffness? Is it limitation of movement? Is it painful movement? Change in size or contour, swelling or redness, pain? Is it unilateral or bilateral? Does it interfere with daily activity? Is there any joint locking or the joint gives way? And what's the sequence of events? And any associated events? Does it become worse in the morning or late in the evening, and efforts to treat? As regards the muscle symptoms, again, you need to ask about what's the character, what's the nature of this symptom. Is there weakness, fatigue, paralysis, tremors, tics, spasms, clumsiness, wasting? And what precipitated these symptoms? Was it secondary to injury, or secondary to strenuous activity, or sudden movement, etc.? Skeletal symptoms, which are symptoms related to the skeleton, mainly your bones. Either difficulty with gait, or either limping, numbness, tingling, pressure sensation, pain with movement, crepitus, deformity or change in skeletal contour, and what are the associated events and efforts to treat and medications. Injury. Whenever there is history of injury, you need to take detailed history about this injury. What did it feel at the time of injury? Did you feel a click, pop, tearing, numbness, tingling, catching, locking, rattling, snapping, warmth or coldness? What exactly happened at the immediate time of injury? And were you able to bear weight after injury, especially for injury in the lower limbs? Mechanism of injury, is it direct trauma, or was it overuse or sudden change of direction? Is there twisting, like twisting injuries, famous for causing meniscal injury of the knee and cruciate ligament injury of the knee, the twisting, sudden twisting movement. Forceful contraction, twisting, this is an S. Okay. And overstretch. If there is pain, again, you need to assess pain as with any symptom with the old cart mnemonic. Let me talk a little bit more about the mechanism of injury. A famous mechanism of injury is fall on an outstretched hand, like when you are about to fall or as you're falling forward, you try to protect your face by stretching your hand, and when the palm of your hand hits the ground, this mechanism of injury can result in one of three famous fractures. It can result in fracture of scaphoid bone, one of the carpal bones. It can result in fracture in the distal end of radius, which is called Colles fracture, or it might result in supracondylar fracture just above your elbow in the lower end of humerus. So these three fractures, any one of them can happen when the mechanism of injury is falling on an outstretched hand. Ask about any swelling, efforts to treat, and medications. For back pain, this is what you need to ask about. Again, the character of pain. Again, you apply the old mnemonic, the old cart mnemonic, associated events, efforts to treat, and medications. This is past medical history, family, and social history. Now let's start talking about examination of the musculoskeletal system, and it's only done by inspection and palpation. Let me first start with the 10 general principles of any musculoskeletal examination. Some things, 10 principles you should put in mind. The first one is symmetry of involvement. You always want to compare both sides. So for example, when the patient comes complaining of limitation of movement in his right elbow, you want to start first by examining the left elbow. Maybe the patient is born with kind of limited mobility of both sides. So you want to start examining the joint that the patient, the side that the patient does not complain about, and then compare both sides. So you should always compare both sides. And when it comes to joint complaints, you want to examine one joint above and one joint below the joint of concern. Again, if the patient comes complaining of any symptom in the right elbow, you will examine the left and then examine the right elbow. And after you're done examining the right elbow, you also want to check the right wrist and the right shoulder. So you want to examine a joint above and a joint below, the nearest joints related to the joint of concern. The third general principle is always look for deformities, any bony overgrowth, partial dislocations, shortening, angulations, contractures, and try to feel for crepitus. Crepitus is this creaking or grating effect that is palpable and sometimes audible. And this crepitus is best felt in old patients with osteoarthritis of the knee. When you put your hand on the patient's knee and ask the patient to flex and extend the knee joint, you will feel this crepitus. It occurs with movement of the involved joint. Crepitus suggests roughening and degeneration of the articular cartilage, which is very characteristic of OA, osteoarthritis, especially of the knee. The fifth general principle is look and assess for the 4 signs of inflammation. And these signs of inflammation: swelling, warmth, redness, and tenderness. So always you want to determine if this joint condition, if this joint complaint is related to inflammatory arthritis or non-inflammatory or minimally inflammatory arthritis. Example of an inflammatory arthritis, rheumatoid arthritis or gouty arthritis. Example of non-inflammatory or minimally inflammatory arthritis, osteoarthritis. So if you notice that there is swelling, warmth, redness, tenderness in the joint, this is most probably of inflammatory nature. So this limits your differential diagnosis options. Always look for the condition of the surrounding skin and tissues. Look for any skin changes, subcutaneous nodules, and an important step is assessing the normal range of motion. Each joint has a normal range of motion, of extension, flexion, abduction, and adduction. And as we go through this PowerPoint, you will see in numbers the range of motion of every joint. Limitation of the range of motion may reflect abnormality. Range of motion should be equal in contralateral joints. So range of motion on both sides should be equal. Range of motion should be assessed both actively, which is done by the patient. You ask the patient to flex the elbow, for example, and also passively. You, the examiner, will try to flex the elbow of the patient for him. Usually, the passive range of motion exceeds the active range of motion by 5 degrees or so, minimal degrees, but usually in general, the passive, the examiner can move the involved joint a little bit more than the patient can actively do so. And as I said, we measure this range of motion in, we measure the angle in degrees. The last two general principles: always assess the cardiovascular integrity, check the adequacy of the circulation, pulses, capillary refill, skin temperature and color, as well as neurologic integrity. Because some skeletal injuries, like bone fractures, can cut an artery or can compress an artery. And this will affect the peripheral pulsations, the capillary refill, and the skin temperature and color. Also, it can compress a nerve, and this can result in change in sensations, paresthesias, or numbness. So always check the cardiovascular integrity and neurologic integrity around the joint of concern. So these are the 10 general principles that should be in mind when we examine any joint or any complaint related to the musculoskeletal system. Actually, this is the last one. Give grade to the muscular strength. We evaluate the muscle strength by moving the joint against resistance. Ask the patient to extend the elbow as you're resisting this. Ask the patient to flex the elbow as you are opposing this flexion, and give it a grade. 0 means no contraction whatsoever, which means complete paralysis. 5 is the normal. What is 5? The patient is able to move against, or the patient is able to withstand strong resistance offered by the examiner. And in between, we have different grades. So these are the 10 general principles we should consider when we examine any joint. Some considerations for special population, history, as well as examination. Dr. Escobedo, who will be giving the pediatric lecture, will definitely highlight the importance of this maneuver, Barlow-Ortolani maneuver, which is an important part of every well child visit during the first year of life. And it detects any hip dislocation or subluxation in the first year of life. Barlow-Ortolani maneuver, as well as other tests related to PEDS patients. Okay, so this is the plan of this afternoon. We have 9 joints to cover. Probably we'll finish the first 8 of them, and we're gonna leave the spine for next week. And actually it's a perfect fit, because next week we're talking about the neurologic system and the spinal cord. It runs down the spinal, the vertebral canal, which is the spine. So this makes perfect fit with the neuro lecture. As for today, we are gonna start talking about each one of these joints. We're gonna talk about what are the abnormalities that can be seen in these joints. And as I said, The steps of examination are only inspection, palpation, and we also assess the range of motion. And sometimes there are special maneuvers related to each joint, and we are going to talk about these special maneuvers to diagnose specific conditions that might affect specific joints. Starting with the easiest joint ever, the temporomandibular joint. And the temporomandibular joint is this joint here. And actually, problems with temporomandibular joint are very limited. Any joint can develop arthritis. What's arthritis? It's a joint disease. And most joint diseases, if not all, are inflammatory or have a certain degree of inflammation. Some joint disorders have minimal inflammatory degree. So these joint disorders like osteoarthritis, minimal inflammatory. Some on the other extreme, septic arthritis, this is the extreme inflammation. How can we know what is the test that would tell us is it very inflammatory or minimally inflammatory? If you take a sample of the joint fluid and measure the leukocytic count of the joint fluid, if it is less than 2,000, that's minimally inflammatory, that's osteoarthritis. If it is more than 50,000, that's the other extreme, which is septic arthritis. In between 5,000 and 50,000, or between 5 and 20, this is usually inflammatory like rheumatoid or gout. In addition to that, of course, when you have inflammation, there will be other manifestations of inflammation. So the TMJ can have arthritis and will be manifest as swelling, tenderness, and decreased range of motion. Also look for TMJ dislocation. And some people have kind of habitual TMJ dislocation, even when with yawning, they can dislocate their TMJ, and because it's habitual, so they themselves can return it back, or sometimes when they cannot return it back, they might come to you to asking for reduction of this dislocation. And this dislocation might be also caused by trauma. And finally, TMJ syndrome. TMJ syndrome means what? Pain and tenderness with palpation on the TMJ without any explanation. So we call it TMJ syndrome, group of symptoms that we cannot explain. So how to examine the TMJ? We inspect the face for symmetry and swellings. We palpate the joint for tenderness, crepitus, popping, locking, and we assess the range of motion. We ask the patient to open and close the mouth, and normally the open mouth should allow 3 fingers of the examiner to pass through. And protrusion and retraction of the lower jaw, and lateral movement of the lower jaw. Assess the muscles of mastication or chewing. And these are 3 groups of muscles: the masseters, the temporalis, and the pterygoids. And these are the TMJ disorders. Assess if it is unilateral or bilateral, either chronic pain with chewing, jaw clenching, teeth grinding, accompanied by headache. And these are the characteristic or the disorders that can be there. So if we see the overall picture, patient might come presenting with 6-month history of pain and popping of the right TMJ. It hurts with chewing, and she tried ibuprofen with some relief and denies tooth grinding. And it's by examination, you find the right TMJ tender to palpation, but there is full range of motion and there is some crepitus. So the provisional diagnosis is right TMJ syndrome, and you might advise the rest cold compresses, ibuprofen, and maybe dental evaluation for night splint. Okay, now let's come to one of the very complex joints, which is the shoulder. And actually, sometimes we refer to the shoulder not as the shoulder joint, but the shoulder girdle. And actually, the shoulder girdle consists of 3 joints. The first one is the sternoclavicular joint, the joint between the sternum, the chest bone, and the medial end of the clavicle. And the second is the acromioclavicular joint, the joint between the distal end of the clavicle and the acromion process of the scapula. And the third joint is the glenohumeral joint, which is what we used to call the shoulder joint, glenohumeral joint. And it's a joint between the humeral head, the head of the humerus bone. What's the humerus? It's the bone of your arm, and the glenoid fossa. And the glenoid fossa of the scapula is characterized by being very shallow. So what does this mean? It means that the head can very easily dislocate out of the glenoid fossa. So the glenohumeral joint is notorious for easy dislocation. So what keeps the head of humerus inside the glenoid fossa, although the glenoid fossa is very shallow? Groups of muscles surrounding the shoulder joint, or groups of muscles, and to be precise, 4 muscles surround the glenohumeral joint, keep the head of humerus in place. And we call these 4 muscles the rotator cuff, the rotator cuff. So the major function of the rotator cuff of the shoulder, they maintain stability of the glenohumeral joint. So glenohumeral joint dislocation is a cause of acute severe shoulder pain with limited range of motion. It's best diagnosed on an axillary X-ray view. This typically is caused by a traumatic event, but if the patient begins having recurrent dislocations, these may occur from minor trauma or normal daily activities. So let's talk now about these 4 muscles, the 4 muscles of the rotator cuff, and if we use their initials, it's going to give us the word SITS. So they are supraspinatus, infraspinatus, teres minor, and subscapularis. These 4 muscles are primarily responsible for stability of the head of humerus in the glenoid fossa, but they also contribute to some movements of the shoulder. And most of shoulder problems originate in one or more of these 4 muscles, because they are very important, not just for keeping the stability, but for accounting for many disorders. And let me explain one thing here. See the muscle, this subscapularis. Each muscle has a fleshy part, which is this red part. And then as the muscle, or as the fleshy part approaches the insertion into the bone, the fleshy part becomes more fibrous. And we call this part kind of a tendon. And the tendon gets attached to the bone. And many times we have in between the tendon and the bone, we have a cyst, and we call it bursa. And this cyst is filled with fluid to minimize the friction between these 2 rough surfaces and 2 tough structures, the tendon and the bone. So we have this cyst, it acts like a cushion to minimize friction. But sometimes this cyst, because of excessive movements, might become inflamed. And this mechanism is called impingement syndrome. What's impingement? Impingement is the compression of a body structure between 2 other bodily structures. So when you compress the cyst between the tendon and the bone, this is impingement. Or if there is a nerve passing here between the tendon and the bone and you compress this nerve, again, that's an impingement mechanism. So this impingement mechanism is an important mechanism of many musculoskeletal symptoms. In addition to the rotator cuff muscles, we have other muscles of the shoulder. Deltoid muscle is the key muscle for maintaining shoulder abduction, and adduction is mediated by pectoralis major and teres minor. In general, abduction, taking the limb away from the midline of the body. Adduction, with 2 Ds, getting the limb closer to the midline of the body. This is what's meant by adduction and abduction. More movement, subscapularis internally rotates the humerus, infraspinatus and teres minor externally rotate the humerus, and more muscle actions. This is kind of anatomy review, but the most important muscles are these four muscles. So if you want to learn by heart something from this slide, it's going to be the sits: supraspinatus, infraspinatus, teres minor, and subscapularis. Okay, now the steps of examining the shoulder. We're going to start with inspection and palpation. We need to inspect the contour of the shoulder from both front and back. Shoulder dislocation will be manifest as flattening of the lateral aspect of the shoulder. And we have a very nice case study about that with clear X-ray about shoulder dislocation. In scoliosis, what's scoliosis? Lateral curvature of the spine. When the spine shows lateral curvature, one shoulder is going to be higher than the other. So there will be asymmetry. There will be asymmetry of the shoulders when there is scoliosis. One shoulder will be higher than the other. And rotator cuff tears may show atrophy at the insertion point with prominence of scapular spine sometimes. Palpate also palpate the bones, like palpate the clavicles, especially following trauma, because you can detect fracture of clavicle following trauma. Again, palpate the bicipital groove and the bicipital tendon to diagnose bicipital tendinitis. Again, the biceps is the muscle in the front of your arm that's responsible for flexing the elbow. And the biceps is inserted in the upper end of humerus. And as it approaches the insertion points, it becomes a tendon. So this tendon usually is covered with a synovial sheath. And there is a synovial fluid between the tendon and the sheath. And this synovial sheath or the tendon itself can be inflamed and becomes source of pain, and this condition is called bicipital tendinitis. Also palpate the subacromial and subdeltoid bursae. Now you know what's a bursa. It's a cyst filled with fluid that separates a tendon from a bone, or two tendons from each other, or sometimes the bone from the skin. So palpate for any bursitis. Inflammation is going to cause tenderness at the anatomical location of this bursa. Also palpate for rotator cuff injury. And usually the four muscles usually get inserted or converge together at this point, at point C. So tenderness over point C, which is the insertion site of the sits, and difficulty abducting the arm above the shoulder level, this occurs in any condition of rotator cuff injury. And this injury can be partial tear, can be total tear, can be inflammatory condition affecting one or more of these four muscles. So tenderness at this point C, together with inability of abducting the arm above the shoulder, can diagnose rotator cuff injury, as we're gonna see in a few minutes. So these are the normal ranges of motions in degrees. So forward flexion, that's the normal range, 180 degrees. Hyperextension, expect only 50 degrees. Abduction, moving the arm away from the midline, expect 180. Moving, this is adduction. This is adduction, moving the arm towards the midline. Okay, and this is forward flexion and hyperextension. Abduction, I have another picture for abduction. Abduction means moving the arm like this. Okay, so these are the normal range of motions of the shoulder, and you examine the shrugged shoulders because this can denote cranial nerve 11 injury. The cranial nerve 11 will be discussed next week. So these are the ranges of motion. And for these slides, I don't want you to get confused with trying to memorize the names of the muscles involved. But what I want you to know, and we will talk about that when we talk about spine next week, I want you to know what is the root of the spinal nerve that is responsible for this motion. Like, for example, shoulder flexion. Let's say it is carried out by the anterior fibers of deltoid, by the pectoralis major, by coracobrachialis, and by biceps brachialis. Let's say that these different muscles receive nerve supplies, and these nerve supplies originate from C5 and C6. Therefore, if you have a patient who is, I'm just giving numbers, examples, throwing numbers. The exact numbers will be found in the PowerPoint of the spine part of the musculoskeletal. So if the patient is unable to do shoulder flexion, so one of the problems can be a problem involving C5 and 6. Some compression on these nerve roots, maybe the patient has cervical disc or something, or osteophytes compressing these nerve roots, and this will be associated also with other manifestations like paresthesias or numbness in the dermatoma. So this is what I want you to focus on, the root of the spinal nerve that supplies these muscles, and don't try to memorize all these names. And this is how you ask the patient to do this movement. And of course, as you can notice, this is a lab talk. The how-to is a lab talk, so I'm not gonna spend more time in it. This is the abduction. It's only important because it diagnoses the rotator cuff. In the rotator cuff injury, the patient is unable to do this abduction, or if he tries to do it, he's going to feel pain. Internal rotation, external rotation. And now let's talk about the special maneuvers. And the most important maneuvers are the ones that diagnose rotator cuff injury or rotator cuff lesions. And there are 5 different maneuvers to assess the rotator cuff muscles. And the best one, you will find this LR, or likelihood ratio, recurring very much. Likelihood ratio is kind of how efficient the test is. So the higher the likelihood ratio, the more specific the test is for certain condition. So the most important test to diagnose rotator cuff lesions is what we call the painful arc test. And we are going to talk about it in details in the next slide. But other tests are internal rotation lag test, external rotation lag test, drop arm test, and external rotation resistance test, and Neer's impingement sign, and also Hawkins impingement sign. So for all these tests, there are detailed videos. You have the actual video here, not just a link for it. So I encourage you to play these videos to learn how to do these tests. But these two, although they are famous, Neer's impingement and Hawkins, but they are less diagnostic than the painful arc test. So now let's talk about painful arc test in more details. The painful arc test means you ask the patient to abduct the shoulder. And this is the normal range from 0, when the arm is just next to the body, to 180 degrees. Patients with rotator cuff will experience shoulder pain between degrees 6 and 120. So in this range, there will be pain somewhere in this range. And of course, with pain, this pain will prevent the patient from going more beyond that point. So this can be rotator cuff tendinitis or impingement of subacromial bursa or any rotator cuff lesion. But this test, painful arc test, does not tell you which one of the 4 muscles has the problem. It tells you that there is a problem in one or more of the 4 muscles. Which one? We don't know yet. This test had the highest positive likelihood ratio. High positive likelihood ratio means it's good specific test. And also it has the best negative likelihood ratio, which means it's a very good sensitive test. So painful arc test, if it is negative, if it is normal, if there is no pain, this excludes rotator cuff injury. Painful arc test, if there is yes pain, this confirms the diagnosis of rotator cuff injury. That's why painful arc test is the most specific and sensitive test for rotator cuff lesions. And again, here is a very nice video about how to do this painful arc test. I really, really encourage you to watch these videos. You have no idea how many hours I spent in watching different YouTube videos to select the shortest and the most demonstrative ones. So of course, you can feel free to watch all the videos on the YouTube regarding certain tests, but I'm trying to spare you the hassle and time waste, and I selected these videos for you. Then, if the painful arc test is positive, we know that there is rotator cuff injury, but the rotator cuff has 4 muscles. So when we do further tests, we can limit the diagnosis to 1 or 2 muscles. Like, for example, so what I want you to know from these slides, the name of the test, external rotation lag test. It is specific for supraspinatus and infraspinatus disorders. Internal rotation lag test will point towards subscapularis problem. Drop arm test will point towards supraspinatus, rotator cuff tear, or bicipital tendinitis. This is not a rotator cuff muscle, but it is drop arm test. If it is positive, it might be bicipital tendinitis, and then you palpate the bicipital tendon and find the tenderness. External rotation resistance test is diagnostic of infraspinatus problems. MTCAN or Jobe test is again diagnostic of supraspinatus. Probably you noticed that the supraspinatus name recurred pretty much. Why? The supraspinatus is the most commonly involved muscle of the 4 muscles of the sits. So the 4 out of the 4 muscles of the rotator cuff, the supraspinatus is the one most frequently injured. So like I can say more than 75%, if not more, of the, if not more than 90% of the rotator cuff lesions will originate from supraspinatus. And this video again is all the steps of examining the shoulder. Now, a patient who comes with shoulder pain, what could be the cause? It could be one of these, the following 10 causes. The easiest actually is the easiest to diagnose, the glenohumeral joint dislocation. It gives very, very characteristic clinical picture. And we will talk about how to diagnose it. Degenerative cervical disc. Here you have shoulder pain, but the problem is not your shoulder, is not in your shoulder. The problem is in your cervical spine, in your cervical vertebrae. Maybe the disc between 2 cervical vertebrae, between C5 and C6 or C6 and C7, the disc is degenerated so that 2 vertebrae become closer to each other. So this means they are going to compress the nerve root, the spinal nerve root, as it exits between the 2 vertebrae, and this causes shoulder pain. And this causes shoulder pain. So bear in mind that pain in the shoulder does not necessarily mean problem in the shoulder. It might reflect pain, or it might reflect a problem in the cervical spine. And this is what I have been telling you. Irritation of the 5th cervical root causes pain in the neck, shoulder, medial scapula, and lateral arm. And this is very important. It causes motor weakness of the deltoid muscle. And there is diminished biceps tendon reflex. This is extremely, extremely important to know. Every root How to diagnose? What's the movement you ask the patient to do that is affected? So sixth cervical root will be weakness of the biceps. The biceps does what? Flexion of the elbow. A patient who is unable to flex the elbow might have sixth cervical root. Seventh cervical root, that's a triceps. Triceps strength will be diminished. So triceps does what? Extension of the elbow. So you ask the patient to flex the elbow against resistance. If he cannot do that, one of the options could be problem in cranial nerve, not cranial nerve, sorry, spinal nerve C6. If the patient is unable to extend the elbow against resistance, you suspect triceps weakness, and this is going to be C7. So this is the importance of knowing the root that is responsible for certain movements. So this is the second cause of shoulder pain. The third cause, impingement syndrome. Impingement syndrome, this is a mechanism of injury. Impingement means you are compressing a bodily structure between two other body structures. And usually this structure is the bursa. It often includes subacromial bursitis or rotator cuff tendinitis because the four tendons, as they approach the point of insertion, they overlap each other. So one of the tendons can get compressed between two other tendons, and this is again impingement syndrome. And this may progress, this itis, this inflammation, can progress to become a partial tear or full thickness tear of the tendon. Okay, all of them result in positive painful arc test, or all of them result are called generally rotator cuff syndrome. Calcific tendinitis. Sometimes you get calcification and degeneration of a rotator cuff tendon. And most commonly, supraspinatus. And the X-ray will often show calcification in the involved tendon. And calcification appears as a dense white part in the X-ray. Bicipital tendinitis, you get tenderness here over the bicipital tendon, and it's very common. And cause number 6, tears or inflammation of the rotator cuff. Usually results from chronic degeneration associated with acute minor trauma or chronic overuse. Like I remember back in Egypt, more than 10 years ago, I used to work with a very eminent, famous head and neck surgeon and ear, nose, and throat surgeon who used to do microlaryngosurgery using the microscope to treat vocal cord polyps, etc. So he spent hours doing these surgeries, shrugging his shoulder like this and manipulating the delicate instruments, trying to navigate his way through the patient's vocal cords. So this type of chronic abuse or overuse of the muscles, he finally ended up having a tear in his right supraspinatus muscle, and he had to do surgery for that. So chronic overuse or chronic trauma usually affects the supraspinatus and might need surgery. Frozen shoulder. This is the sequela or the complication of a rotator cuff inflammation. Inflammation of the rotator cuff, for whatever reason, might heal with fibrosis. And when you have inflammation, it hurts when you move your shoulder, so you try to limit the movement of the shoulder. And when you don't move your shoulder because it hurts, because you have inflammation, gradually your shoulder will become kind of frozen. And this frozen shoulder will be more and more helped by the fibrous tissue that develops as this inflammation heals by fibrosis. So you end up having some sort of adhesions in your shoulder, and this is called frozen shoulder or adhesive capsulitis. And it's a very painful condition that results from idiopathic inflammation and soft tissue scarring, contracture in the joint capsule. An X-ray might show calcification of the involved tendon. And again, diabetes and hypothyroidism increase the risk of developing this condition, as well as any trauma, overstretching or chronic use or whatever can result in inflammation, and this inflammation limits the movement. So you're afraid of moving your shoulder, and the inflammation heals by fibrosis. Frozen shoulder is a very, very, very common. Probably some orthopedic surgeons consider frozen shoulder whenever a patient goes to an orthopedic surgeon with a complaint of shoulder pain. They assume it is frozen shoulder until proved otherwise, especially when it comes to chronic shoulder pain. Okay. Glenohumeral or acromioclavicular arthritis. Again, any joint is subject to have arthritis. When I say arthritis, I want 4 names to pop into your mind: osteoarthritis, rheumatoid arthritis, gouty arthritis, septic arthritis. Whenever I say arthritis, I want these 4 names to pop into your mind. Any one of them can happen in any one of the 3 joints of the shoulder girdle, as well as septic shoulder, which is septic arthritis of the shoulder. And last one, don't forget that you can get pain in the left shoulder when you have angina, ischemic heart disease, and pain in the right shoulder if you have gallbladder problem. Okay, so pain of the shoulder can be coming from the heart, actually. So these are the 10 causes of shoulder pain. So let's see the overall picture. Let's look at this case. 18-year-old male presents with severe pain in the right shoulder that happened suddenly as he was attempting to throw the ball during baseball game. Patient also reports difficulty moving the arm with numbness, tingling in the upper arm. The right arm is, this is adducted, adducted, kept very close to the body, adducted, and externally rotated. Externally rotated means the palm of the hand faces forward, faces anteriorly. There is flattening of the normal round contour of the right shoulder. Look at this normal shoulder. Look at the contour. Nice and round. Look at the contour here. Kind of angle. So the contour is kind of angled. And there is a little bulge, shows right below and toward the front of the top of the arch. See this bulge? This is what? This is the head of the humerus that dislocated anteriorly and downward. It dislocates anteriorly and downward from the glenoid fossa. And there is pain on any attempted movement of the shoulder. This is acute anterior dislocation of the right shoulder. It needs to be reduced at the ER. Reduction of this dislocation in the ER. Some patients with habitual shoulder dislocation, they can reduce it themselves. And they don't need to go to the ER. 57-year-old man who works in painting houses presents with pain in his right shoulder that he started to have 3 weeks ago, and he has become, and the pain has become more lately. And what worsens the pain is lifting the arm, and the patient has been doing his job with difficulty because of that. And these are the positive tests. Positive painful arc test. This is going to tell you that one of the 4 muscles, one or more, is damaged, and other tests will try to narrow your diagnosis to 1 or 2 muscles. Eventually, you will have to do MRI, of course, to locate the exact muscle that is involved. Okay, now moving on to a less complicated joint, the elbow. Let's talk about some important anatomy of the elbow. And I usually include the items I want you to focus on in this box. First, we start talking what are the bones involved in the elbow joint. And there are three bones. The bone of the arm, which is the humerus, and the two bones of the forearm, the radius and ulna. Now, the radius is always the lateral bone, and the lateral bone is on the side of the thumb. Lateral means outer, away from the midline of the body. That's the radius on the thumb side. The ulna is the medial bone of the forearm. It's on the little finger side. So the elbow is a joint between these two bones, radius and ulna, the upper ends of them, with the lower end of the humerus. And the lower end of the humerus has two bony projections on each side, and they are called lateral and medial epicondyle. You can feel them, you can palpate them right now. Put your fingers here at the lower end of your arm, and you are going to feel two bony prominences, lateral and medial epicondyle. The medial epicondyle in particular has the ulnar nerve passing just underneath it. And if you tap here, if you tap on the medial epicondyle, if you tap on the ulnar nerve here at the medial epicondyle, you can get this electric sensation, this tingling that shoots down your forearm, even into the little finger and the medial part of your hand. So this is the ulnar nerve. This is important because sometimes the ulnar nerve becomes entrapped here and compressed on. The olecranon is the uppermost part of the ulna. This is the olecranon, uppermost part of the ulna that articulates posteriorly with a fossa on the lower end of the humerus. So these are the important structures that I want you to focus on. See the medial epicondyle and see the ulnar nerve in yellow. It passes right behind the medial epicondyle. And of course, here it's covered by muscles and tendons and other structures. So it can become compressed between the medial epicondyle and the structures that pass above the ulnar nerve. Examination of the elbow, starting by inspection and palpation. We inspect for olecranon bursitis. Again, what's the olecranon bursa? It's a bursa between the olecranon process and the skin. It's a bursa because the olecranon process is very superficial here. So there is a bursa to minimize friction between this bone and the skin. So this is the olecranon bursitis. And also look for any swollen joint. This can denote arthritis, or this can be manifested as this swelling can tell you that there is arthritis. Palpate the olecranon process again and press over the epicondyles. Tenderness over the epicondyles can be epicondylitis. Lateral epicondylitis is famous for the name tennis elbow, and medial epicondylitis is also called golfer's elbow. We are going to talk about them in a minute. Look for any displacement of the olecranon process. So this is the olecranon process. Normally it should be here. But when you have posterior dislocation of the elbow, the olecranon process leaves its nest at the lower end of humerus and is dislocated posteriorly. And this is the supracondylar fracture. Again, supracondylar fracture is one of three fractures that you can get when you fall on an outstretched hand. What are these three fractures? Scaphoid fracture and a fracture lower end of radius, and a fracture of the supracondylar fracture. You will be surprised who taught me this, the three fractures that you get when you fall on an outstretched hand, and when I learned this. I probably learned this when I was maybe 10 years old, 11 years old, or even younger, because my father, he's now in heaven, was an orthopedic surgeon. So actually he told me, and I actually learned how to read x-rays of bone fractures because my father had huge library of x-rays for the musculoskeletal system. Range of motion. Again, these are the different movements with the range of motion, primary muscles involved, and how to ask. about them. And now let's talk about the 5 causes of painful elbow. The patient comes with painful elbow. What could be the problem? Painful elbow. The first cause is olecranon bursitis, inflammation of the olecranon bursa. Again, where is the olecranon bursa? It is between the olecranon, which is the upper part of the ulna posteriorly, and the skin. So this is the olecranon bursa. It might be inflamed. It can be inflamed without a known reason, or can be inflamed due to trauma or gout or rheumatoid arthritis. And elbow motion is unaffected and not significantly painful. Rheumatoid nodules. Patients with rheumatoid arthritis might develop subcutaneous nodules near the elbow along the extensor surface of the ulna in patients with severe rheumatoid arthritis or acute rheumatic fever. These nodules are firm and not tender and not attached to the overlying skin. Arthritis of the elbow, whether septic arthritis or rheumatoid arthritis or gout or pseudogout or osteoarthritis or secondary to trauma, can result in swollen, tender elbow. Cubital tunnel syndrome. This is an impingement of the ulnar nerve or entrapment of the ulnar nerve as it passes posterior to the medial epicondyle. Entrapment of the ulnar nerve in the cubital tunnel on the medial side of the elbow causes pain in the elbow, as well as sensory/motor changes in the hand. Where in the hand? In the territory of the ulnar nerve, which is the medial 1/3. Medial 1/3 of the palm. Medial 1/3 of the palm. This is the territory of the ulnar nerve. There is numbness and tingling of the ring and small fingers. Again, these 2 fingers, this is the territory of the ulnar nerve, particularly at night, which is a common complaint. So if you gently tap over the cubital tunnel, where is the cubital tunnel? Right behind, posterior to the medial epicondyle, this will reproduce the pain and tingling. So if you're able to reproduce the symptoms by tapping on the ulnar nerve behind the medial epicondyle, and you are able to reproduce the symptom, this is positive Tinel's sign at the elbow. We have Tinel's sign at the elbow, and we have the same test done for carpal tunnel by tapping over the flexor retinaculum at the wrist, as we're going to see in a few minutes. The problem of cubital tunnel is aggravated by repeating bending motions of the elbow, or holding the elbow flexed for long periods, like talking on the phone, flexing your elbow like this, or resting the medial elbow on the car door during long drive. And it might need surgical intervention. Ulnar nerve entrapment or cubital tunnel syndrome. And finally, epicondylitis. Lateral epicondylitis, inflammation of structures around the lateral epicondyle, is called lateral epicondylitis, called tennis elbow, because this movement, the famous backhand movement of tennis players, aggravates the condition or worsens the pain, versus medial epicondylitis, inflammation of structures around the medial epicondyle, is called golfer's elbow, because this movement, which is famous movement done by golf players, again aggravate the condition. So lateral epicondylitis, it follows repetitive extension of the wrist or pronation supination of the forearm, pronation supination of the forearm. And there is pain and tenderness 1 centimeter distal to the lateral epicondyle on the posterior side, dorsally. So dorsally and distal. Dorsally, this is the lateral epicondyle, 1 centimeter distal. Distal means towards your hand, away from the origin, point of origin, away from the shoulder. Distal and lateral, 1 centimeter distal to the lateral epicondyle on the dorsum, on the posterior aspect of the arm. Activities like grasping, playing tennis, or even giving a firm handshake make the pain worse. And if you ask the patient to extend his wrist against resistance, this increases pain. So this is how to diagnose lateral epicondylitis or tennis elbow. Of course, in any test, if you see a tennis player in the question stem, this means the examiner wants you to answer lateral epicondylitis. If you see a golf player, this means the examiner wants you to choose medial epicondylitis. Again, medial epicondylitis follows repetitive wrist flexion. Tenderness is maximal, actually this is medial. No, it's lateral, because you cannot go more medial beyond the medial epicondyle, because the medial epicondyle is the most medial structure, right? So it is inside the forearm. So it's a little bit, it's slightly lateral, like because if you go more medial, then the epicondyle, this is air. This is the air between your arm and your trunk. This is when you go medial. So tenderness is maximal, just lateral and distal, lateral and distal to the medial epicondyle. Okay. Wrist flexion against resistance increases the pain. See the difference? How to test for medial epicondylitis? Wrist flexion against resistance. How to test for lateral epicondylitis? Wrist extension against resistance. Complications, ulnar nerve neuropathy and or palsy. That's a long-term pressure and damage. Complaints of numbness, tingling on the little finger and weakness of the hand. Worst case scenario is development of a permanent deformity called claw hand. Claw hand like this. The patient has this deformity in the fingers because of long-term compression on the ulnar nerve. That's medial epicondylitis. Okay, let's see the overall picture. 25-year-old female left-handed tennis player. What are you going to answer? You see tennis player in the question stem. The answer is lateral epicondylitis. Pain in her left elbow for a few months. She's left-handed. So obviously she's using her left side more. So that's why she got this lateral epicondylitis on the left side. Pain gets worse by playing tennis, as well as attempting to open jars, sometimes after shaking too many hands. There's tenderness over the left lateral epicondyle. That's lateral epicondylitis. Okay. Last joints in this PowerPoint set, the wrist and hands. Let's talk about some anatomy. What are the bones involved? What are the bones involved? So we talked about the two bones of the forearm. The two bones of the forearm are radius and ulna. Now, the carpal bones are the bones of the wrist. The carpal bones are the bones of the wrist. And there are 8 carpal bones, 8 carpal bones. The most clinically important one is the scaphoid bone. Why? For many reasons. Fracture scaphoid is one of the 3 fractures that complicate this common mechanism of injury, fall on an outstretched hand. The second reason is fracture of scaphoid bone might not show in an early X-ray. It might take a week or more for fracture of the scaphoid bone to show on the X-ray. But from day one, you can diagnose it clinically. Third reason why the scaphoid is important, because fracture of the scaphoid bone is one of the worst fractures when it comes to healing. It takes a long time to heal. Sometimes it might need surgery to make sure that the 2 parts of the fractured bone are in place and not displaced. It's a bad type of fracture. So the scaphoid is the most important one, clinically a significant one of the 8 carpal bones. Carpal bones are the bones of the wrist. Metacarpal bones are the bones of the hand, the palm of the hand. Metacarpal bones are the bones of the hand. Phalanges are the bones of the fingers, of your fingers. These are the names of the bones. Then the names of the joints. The joint between the metacarpal and phalanges, the knuckles, this is the metacarpophalangeal joint. Metacarpophalangeal joint, the MCP. And the phalanges have two joints, proximal interphalangeal joint, PIP, and distal interphalangeal joint. Why is it important to know this? Because the distal interphalangeal joint is a very characteristic joint. Rheumatoid arthritis usually spares this joint. Rheumatoid arthritis rarely affects the DIP, whereas osteoarthritis affects the DIP. That's why DIP have a significant diagnostic value. Okay, so these are the joints. Now, the carpal tunnel. What's the carpal tunnel? As you can see, these 8 bones are 8 tiny small bones. What keeps them in place? A tough sheet of tissue called the flexor retinaculum, kind of fibrous, strong sheet of tissue. This flexor retinaculum is holding tight these 8 bones together. So it extends horizontally over these 8 points, these 8 bones. And the median nerve passes underneath the flexor retinaculum. So this means like the ulnar nerve up there in the elbow, the median nerve down there at the wrist can become entrapped and compressed between the flexor retinaculum and the carpal bones. And this results in carpal tunnel. So cubital tunnel is entrapment of the ulnar nerve at the elbow. Carpal tunnel is entrapment of the median nerve at the wrist. And chronic median nerve compression can lead to atrophy of the thenar eminence. This is the thenar eminence, the bulk at the base of the thumb. So if you have chronic compression on the median nerve, this bulk becomes atrophied and flattened. Okay, so this is some important anatomy. And actually, I have to proceed faster. Examination of the hand and wrist. Look for the motion of hands. If it is smooth or guarded movement might suggest injury. Normal fingers are slightly flexed. Look for any swellings. Maybe there's arthritis, infection, ganglion. Look for deformities like the famous bone nodes. In osteoarthritis, you have Heberden nodes at the DIP or butchered nodes in the PIP. Deformities in rheumatoid arthritis, you have ulnar deviation or Bottier-Nares deformity. Atrophy of the thenar eminence can diagnose carpal tunnel syndrome, or the hypothenar, which is the bulk below the little finger, can diagnose ulnar nerve compression. Look for any abnormal contractures, like this contracture that usually involves the 4th finger, called Dupuytren contracture. And trigger finger, that also usually involves the 4th finger. Palpate the wrist for swelling, tenderness over the styloid process of the radius. Anatomic snuff box tenderness. This diagnoses scaphoid fracture. Occult scaphoid fracture. Occult because it might not show in an early X-ray, but there is anatomic snuff box. When you do this groove is called the anatomic snuff box. Tenderness here can diagnose scaphoid fracture. MCP joints, the most commonly involved joints in rheumatoid arthritis. PIP for butchered nodes in osteoarthritis. DIP usually spared in rheumatoid arthritis. This is the range of motion for the wrist and the range of motion for the fingers. Now, special maneuvers. First, you need to test sensation in the hand. And let's know the territories. So the mid-ulnar nerve supplies the medial 1/3 of the palm, and the little finger and the medial half of the ring finger. the median nerve supplies the lateral 2/3 of the palm and the lateral 3.5 fingers. So if you want to test the sensation in the pulp of one finger to tell you about the median nerve, it's going to be the index. So the index is the finger that will tell you that there is a problem in the median nerve from the palm side. And the little finger, and not the ring finger, is the finger that would tell you there is a problem in the ulnar nerve if you have impaired sensation. Okay. As for the radial nerve, it supplies the dorsum of the hand, and the best place to test for radial nerve is the web space of the thumb and index finger. This web space on the dorsum of the hand, if you have impaired sensation in it, this can be a problem in the radial nerve. Hand grip. Ask the patient to grasp your second and third finger using the thumb side of the hand. This is very important. So you put your two fingers on the thumb side of the patient's hand, because if it takes real weakness to enable you to get your two fingers out of the thumb sides. But it's very easy to get out of the little finger side because there is no thumb here on the little finger side to make a firm grip. One of the functions of the thumb help us make a firm grip. So this, as in this picture, see? So this is the examiner's hand and this is the patient's hand. So you put your two fingers near the thumb, from the thumb side of the patient. If there is weak hand grip, it could be degenerative arthritis, it could be epicondylitis, it could be carpal tunnel syndrome, it could be cervical radiculopathy. But if there is grip weakness and pain in the wrist, it can be Decker-Van tenosynovitis. Let's talk more about this. Decker-Van tenosynovitis is inflammation of the abductor pollicis longus and extensor pollicis brevis tendons and their tendon sheaths. And there will be weak hand grip and wrist pain. And the test that we should do to diagnose it is Finkelstein test. And this is how we do Finkelstein test. Ask the patient to make a fist holding the thumb and extend or hyperextend the wrist like this. And this movement should bring severe pain at this point. And this is the Finkelstein test. And again, this video illustrates the test. Special tests for carpal tunnel syndrome. We have different tests: Durkan's thumb abduction, Tinel sign, and Fallon sign, different tests. By far, this is the most sensitive test, carpal tunnel. Carpal tunnel compression test or Durkan test. Of course, if I put it in the test, which test is most sensitive, and I put the name carpal tunnel compression test, I'm giving you the answer, literally. But if I put Durkan's test, and you know that Durkan's test is another name for carpal tunnel compression test, then you choose this one as the most sensitive test for carpal tunnel syndrome, okay? And this is how we do it. You keep compressing the carpal tunnel for 30 seconds and see if you can reproduce the symptoms, the pain and paresthesia in the median nerve territory of the hand. Okay, arthritis in the hand, acute rheumatoid arthritis can involve hand joints with tender, painful, stiff joints. And this stiffness is very prolonged early morning for 1 hour. And usually it is the MCP and PIP. DIP is much less commonly affected. Chronic rheumatoid arthritis, again, in the knuckles and PIP and the wrist, and there are deformities, swan neck deformity, Bottier and ulnar deviation. Osteoarthritis, it involves even the distal interphalangeal joints. You can get nodes, Heberden nodes and Butcher nodes. Chronic tophaceous gout, you can have tophi around the joints like this. Dupuytren contracture. This condition is thickened band overlying the flexor tendons of the fourth or fifth finger. And subsequently, the skin puckers and a fibrotic cord develops between the palm and the finger, like this. That's Dupuytren contraction. Trigger finger. This is caused by a painless nodule in the flexor tendon of a finger in the palm. And it results in a palpable and sometimes audible snap that is noticed on attempting, extending, or flexing the finger with an extra effort or with assistance. Thenar atrophy might suggest median nerve compression at the carpal tunnel syndrome. Ganglion. This is pretty common. It can be on the dorsum or the ventral aspects. It's cystic round, usually non-tender swelling along tendon sheaths or joints, capsules frequently at the dorsum of the wrist, but could happen anteriorly too. Tenosynovitis of the hand. We have different types of tenosynovitis. This is the one I want you to focus on, the Ducker-Van tenosynovitis. We talked before about it. It results in wrist pain, weak hand grip, positive Finkelstein test. And this is, by the way, the anatomic snuff box. This is the anatomic snuff box. Tenderness here at the anatomic snuff box following fall on an outstretched hand is diagnostic of scaphoid fracture, even if the X-ray does not show it. Okay, let's see the overall picture. Joint pain in the wrist. 22-year-old male fell out skateboard. There's tenderness over the anatomic snuff box. Here you're lucky because the X-ray shows a fracture. See this transverse slit, this kind of gap. That's the fracture scaphoid. That's or scaphoid fracture. This is what we call avulsion fracture, distal phalanx. You can read it. Boxer fracture. Again, you can read about it. This is Colles fracture. Fracture distal end radius. It results in a very characteristic deformity, what's called dinner fork deformity of the left wrist. One of the very famous phrases to help you answer a question on the test, dinner fork deformity. This is Colles fracture. What's Colles fracture? It's fracture distal end radius at the wrist. Fall on an outstretched hand. Okay, and this concludes the first part. Let me stop recording. I'm going to resume recording and now share part 2 of musculoskeletal PowerPoint. Are you able to see this slide?
Yes.
Thank you. So in this slide, we're going to be talking, in this set, we're going to be talking about the muscle, the joints of the lower limb, the hips, knees, and the ankle, and the spine. We're going to be discussing it next week. So the hip is that joint between the head of humerus and the acetabulum of the iliac bone. And here the acetabulum is deeper, not as shallow as the glenoid fossa up there in the shoulder. Therefore, dislocation of the hip can happen, but not as common as shoulder dislocation. And this greater trochanteric spine, or the great trochanter, this projection on the upper lateral part of the humerus, is covered by a bursa called trochanteric bursa. And actually, pain in the outer part of the hip, in the outer part of the hip joint, the most common cause of pain in the outer part of your thigh, upper outer part of your thigh, is usually trochanteric bursitis. This is very common cause. We have other bursas here. We have ischial bursitis and ischial bursa, but this trochanteric bursitis is the most common cause of pain. You need to know the location, what's the iliac crest, what's the iliac tubercle, where is the anterior superior iliac spine and posterior superior iliac spine on the back, and ischial tuberosity and sacroiliac joints. Now, examination of the hip. It's important to examine the gait. And here, let me talk about 2 phases of the gait: stance and swing. So when you're walking, sometimes your foot is on the ground and bears weight, and this is the stance phase. It occupies 60% of the walking cycle. And then when the foot is lifted to move forward, and now it does not bear weight, this is the swing phase, which accounts for 40% of the walking cycle. So you need to look, and usually, if there is a problem, it will be manifest during the stance phase. It will be manifest during the stance phase, because this is the phase where you're bearing weight. Inspect the gait for the width of the base and assess the length of legs for symmetry. Asymmetrical length, of course, will denote a problem. Palpate bony landmarks of the hip anteriorly and posteriorly. Palpate the inguinal structures at the inguinal ligament. And if you remember the word navel, these are the structures from lateral to medial. Most lateral is the nerve. Then as we move medially, there's an artery, vein, an empty space, and then lymph node, navel. Palpate for trochanteric bursa. Again, tenderness at the trochanteric bursa is a common cause of the pain in the hip joint. Palpate the ischiogluteal bursa on the back. These are the different movements and the primary muscles involved and how to ask about the hip, and some special maneuvers. Testing for hip flexion, testing for hip extension, testing for abduction, and testing for adduction, and testing for external and internal rotation. How to do all these tests, this is a lab talk. And Thomas test and Trendelenburg test. Actually, Trendelenburg test is an interesting one. It detects weak hip abductor muscles. When the iliac crest drops on the side of the lifted leg, the hip abductor muscles on the weight-bearing side are weak. So let me explain this. Normally, when you walk, whether you lift this side or you lift, whether you lift this foot or you lift the other foot, the normal abductor muscles of the hip will maintain the level of the iliac crest at the same level, of both iliac crests at the same level. But if you notice that this side drops too much, the side of the lifted leg, lifted foot, where is the problem? I said always the problem will be on the weight-bearing side. So this means if this side, the lifted foot, when during the swing phase, the iliac crest drops too much, this means that the abductor muscles on this side are weak, on the side of stance. So always the abnormality is on the side of the foot that is touching the ground, that bears weight. So that's Trendelenburg test. Okay, so this diagnoses weakness of the abductor muscles on the weight-bearing side. It's always the weight-bearing side that has the problem. In other words, when this foot is on the ground and this foot is off the ground, the two iliac crests will be normally aligned. But when this one drops too much because the other side cannot keep this iliac crest low enough. Faber test and Fader test, I'm going to leave them for you to read. They are not very clinically significant. Now let's talk about causes of painful hip. Greater trochanteric bursitis. Here the pain occurs laterally over the hip, just posterior to the greater trochanteric bursa, and may radiate down to the lateral leg, to the foot, mimicking sciatica. This is the most common cause of painful hip, apart from, of course, hip fractures. And lumbar spine disorders. Herniated lumbar disc can cause pain in the hip as well. Intra-abdominal pathology can cause pain in the hip joint. Retroperitoneal bleeding, inguinal hernias, septic hip arthritis. Septic arthritis of the hip joint can also result in severe pain. So pain in the hip can be arthritis, tendinitis, or bursitis, and of course, fracture hip. Fracture hip is common, especially in elderly. And let me say one word about fractures of the hip in elderly. Previously, we thought that the order, the sequence of events is the guy or the lady, they fall down, and because of this, they fracture their hips. Now we understand that this can happen in the reverse order. Because of the osteoporosis, the weak bones, the hip bones may fracture first, and this fracture will be the cause of falling down. So the fracture can be the cause or the result of falling down. Now let's come to, again, a very complex joint, which is the knee. And this is the most important weight-bearing joint in the body. Let's start by anatomy. The knee joint is mainly between the lower end of the femur, which is the thigh bone, and the upper end of the tibia, which is the leg bone. Although the leg has two bones, medially we have the big tibia, and laterally we have a very thin, slim bone called fibula. And the fibula is not a direct bone of the knee joint, but because one of the ligaments of the knee joint, the lateral collateral ligament, extends between the femur and the fibula, this is the only reason why we might include the fibula in the knee joint. But the fibula is not articulating, if you will, is not directly articulating with the femur, okay, at the knee joint. What is directly articulating with the femur? It is the upper end of the tibia. Now, there is a cartilage that covers the upper end of the tibia, and this is the articular cartilage of the joint, which is called the meniscus. On the medial side, it is the medial meniscus. On the lateral side, it is the lateral meniscus. This cartilage can be injured with twisting or rotational movements at the knee. And this is common mechanism in soccer players, football players, basketball players, especially in soccer players. Any twisting, rotational movements at the knee can injure. Most commonly, is it the medial side or the lateral side that is injured? Most commonly, it is the medial side. Why? The medial side is very firmly attached to the bone, so there is no leeway for it. But the lateral meniscus is loosely attached to the bone, so even with rotational movement, it can have a leeway and escape getting injured or torn. We have the collateral ligaments, lateral collateral and medial collateral, not very important. And then we have very important ligaments, the posterior cruciate ligament, and the most important ligament of all ligaments in the knee joint is the anterior cruciate ligament. And this is the only ligament that is inside the joint cavity. All the ligaments of the knee joint are outside the joint cavity, except the anterior cruciate ligament. It is inside the joint cavity. Inside the joint cavity. And therefore, if you get anterior cruciate ligament tear, the joint cavity will be filled in minutes with massive amounts of blood, and you get massive effusion of the knee joint. The knee joint swells in a couple of hours maximally. It becomes a bag of blood. Anterior cruciate ligament is the worst injury. Anterior cruciate ligament injury is the worst injury that any player, a basketball player or soccer players can get. So these are the articulating bones. The patella. The patella is a superficial bone located anterior to the upper end of tibia. Anterior to the upper end of tibia. This is the patella. this one. Lateral and medial menisci, we talked about them. Lateral and medial collateral ligaments, anterior and posterior cruciate ligaments, we talked about all this. Okay, so this is mainly what I want to talk about in the anatomy. Examination. In order to fully examine the knee, you have to comment on 7 structures. 2 menisci, 2 collateral ligaments, 2 cruciate ligaments, and the patella. So there are 7 structures: 2 menisci, 2 collaterals, 2 cruciates, 1 patella. 2 menisci, 2 collaterals, 2 cruciates, 1 patella. So have this scheme in mind as we're talking about examination of the knee. Inspect the gait. Look for stumbling or giving way of the knee during heel striking the ground, suggests quadriceps weakness. Alignment. Bow legs and knock knees. So genovalgum, this is knock knees. And the way I remember it, it's genovalgum, so as if you had a piece of gum making the 2 knees stuck together like this, piece of gum. That's genovalgum. Normally there is a distance, reasonable distance between the 2 knees. If this distance is big, causing the legs to show this bow, we call it genovarum, okay? So this is the way I remember. It's always enough to remember one thing in order to remember the opposite, the other one. So if you just remember genovalgum, the 2 knees are stuck together by a piece of gum, then no need to memorize what's the genovarum. Genovarum is going to be the opposite of genovalgum. That's very clear picture of genovalgum, and this is genovarum. Look for any swellings, bursitis, or something like that. Palpate the different joints, palpate the different bursas. One of the very commonly inflamed bursas is the anterior or pre-patellar bursitis. This bursa is anterior to the patella and is triggered, bursitis is triggered by excessive kneeling. We call it housemaid bursitis. And serine bursitis commonly inflamed in runners and bicycle riders. Baker cyst, that's on the posterior aspect in the popliteal fossa, and usually occurs from rheumatoid arthritis. Palpate the patellofemoral compartment for prepatellar bursitis. This is very common, the housemaid bursitis. Look for pain during contraction of the quadriceps. This occurs in chondromalacia. We're going to talk about this condition in a second. Test for knee effusion. There are 3 tests for knee effusions. How to do them, these are the videos for how to do them. The test to detect minor effusion is called bulge test or bulge sign. And the tests to detect major effusion are called balloon sign and ballotting of the patella for major. The way I remember it, minor effusion, the name of the test has 1 L. For major effusion, you have double L's, 2 L's in the name, balloon, ballotting, so because the effusion is major. This is how I remember them. These are the range of motions and different movements and how you ask about them. Now, let's talk about special maneuvers. This is very important. How to test for the menisci, medial and lateral meniscus. McMurray test will test for both. McMurray for both. Why then is it most of the time linked to medial meniscus? Because the medial meniscus is the one that most commonly tears. And when they ask you in a test, what is the physical finding that will tell you a medial meniscus tear, because this is the one most commonly injured because it is tightly attached to the bone, then the answer would be McMurray. But McMurray test actually can also diagnose lateral meniscus tear. We're going to see how. So this is how you do it. So if the external rotation of the lower leg is very painful, it diagnoses medial meniscus tear. If the internal rotation of the lower leg is very painful, this diagnoses lateral meniscus tear. This is McMurray test. Is it accurate? The answer is no, it is not that accurate. Testing for medial and lateral collateral ligaments. The abduction test for medial collateral ligament and the adduction test for the lateral conduction ligament. It is the opposite of the name. What's abduction? Taking the joint away from the midline, taking the limb away from the midline. Abduction, taking it away, it stresses the medial collateral. Adduction, bringing the limb towards the midline, it stresses the lateral collateral. So test for collateral, the opposite of the name. Abduction for the medial, adduction for the lateral. Now tests for the anterior cruciate ligament. Look at this asterisk. This is a warning thing. Always exclude posterior cruciate ligament injuries before testing for the anterior cruciate ligament injuries, which means which ligament are you gonna examine first, the posterior or the anterior? The answer is always start with the posterior. Always start with the posterior. Make sure that there is no posterior ligament injury, and then you can examine the anterior cruciate. Simply because if there is a posterior cruciate ligament injury, you will be unable to do the tests for the anterior cruciate ligament. And the patient might complain of pain when you do the tests for anterior cruciate ligament. This pain is not coming because the anterior cruciate ligament is torn, but it is because the posterior cruciate ligament is torn. That's why we start first by posterior cruciate ligament tests, and these are the posterior cruciate ligament tests. The posterior drawer sign, how we do it, this is how we do it. If it is normal, if there is no pain, then this excludes posterior cruciate ligament. Then we go back and examine the anterior cruciate. Okay, you get that? There are two tests for examining the anterior cruciate ligament. The anterior drawer sign, and you have the drawings and the video, and the Lachman test or the Lachman test. ACL injuries result from knee hyperextension or direct blow to the knee and twisting or landing on the extended hip or knee. Okay, very common and serious injury in sports. We talked about the posterior cruciate ligament. Okay, this slide is going to be a question in the coming test. The Ottawa knee rules. Indications of knee X-ray. When are you going to order an X-ray for the knee joint following knee injury? Does any patient who sustains knee injury needs X-ray for the knee? The answer is no, never, because you don't need to expose patients to unnecessary radiation. There are 5 conditions. Any patient who sustains knee injury, any one of these 5 conditions will be an indication of X-ray for them. The first is age. So this is something even before you see the patient. If someone tells you, hey, there is a 60-year-old patient with a history of knee injury waiting for you in the ER, before you go, you order X-ray first, just based on the patient's age. Second, isolated patella tendons. If everything is perfectly normal in the knee and only the patella is tenderness, it might be fracture of the patella. So order X-ray. Tenderness at the head of the fibula. Where is the head of the fibula? The upper outer aspect of the leg. This is where the head of the fibula is. Again, if there is tenderness at this point, it can be fissure or fracture of the head of the fibula, order X-ray. Inability to flex the knee 90 degrees. So order X-ray. Finally, inability to bear weight. And how to test for bearing weight? 4 steps, not just 1 step, 4 steps. If the patient is unable to walk for 4 steps, immediately after injury, so you know this by history, and in the emergency department, you know this by examination, inability to bear weight, this is an indication of X-ray. Any one of these 5, you don't have to have the 5, all of them together. Any one of these 5 following knee trauma, this is an indication of X-ray to the knee, of the knee. Abnormalities of the knee joint. Arthritis. Osteoarthritis, the knee joint is the most common joint in the body involved in osteoarthritis. Why? It is the most important weight-bearing joint. It's the most important joint when it comes to bearing weight. The knee joint is the most important. And you can feel the crepitus very easily over the knee joint. Rheumatoid arthritis, usually when rheumatoid arthritis affects the knee, not usually, sometimes you can identify the Baker cyst on the posterior aspect of the knee joint. Bursitis, inflammation and thickening of bursa. It can involve the pre-patellar bursa with repeated kneeling, and that's why we call it housemaid bursitis, or the pes and bursa anteriorly and medially, especially in runners. So you have tenderness at this point. This is the pes and serine bursa anteriorly and medially. Pre-patellar bursa, right in front or superficial to the patella. These are the 2 most commonly involved. Chondromalacia. What's this chondromalacia? Aggravation of anterior knee pain during weight bearing with the knee in flexion, like during stair climbing, going upstairs, arising from a sitting position. You're sitting on a chair and you're arising and you get pain in the anterior knee. This suggests chondromalacia, aka patellofemoral syndrome. It's common. It's a common condition. Chondromalacia develops when the patella is pulled off toward one side of the knee by the quadriceps muscle. And a sign to diagnose it is called the increased Q angle. I'm going to leave this details for you to read. This is common among young and middle-aged females. Chondromalacia, young, middle-aged females. It's like any autoimmune disease, but this is not an autoimmune disease. Although we don't know exactly what causes it, that's why we call it patellofemoral syndrome. On examination, the brain test will often be positive, which is palpable crepitus and or pain that occurs when the examiner compresses the patella into the trochlear groove as the patient flexes and extends their knee. And this is how to do the test. There may be signs of patella maltracking, like the J sign. This is too much details. It's just enough to know what's the presenting symptoms. You get aggravated anterior pain, anterior knee pain with stair climbing or arising from a sitting position. That's chondromalacia. Meniscal tears. Medial meniscus sustains injury much more than the lateral because the medial meniscus is more firmly attached to the tibia than the lateral meniscus. A sudden twisting movement, that's the mechanism of injury. Also aging, weakness the menisci. Following a meniscal tear, pain can be severe and is typically localized to the medial or lateral joint line, depending on which side is torn. And there is swelling at the joint line, and there is clicking, popping, or locking sensation. But usually, meniscal tear, if it happens to a player during the game, interestingly and surprisingly, that player can be able to continue the game. So it's painful, but not to the extent of preventing the player from continuing the game. Okay, but anterior cruciate ligament injury, the player will never be able to continue the game. Okay, so as you're watching the games, you know, there is nowadays there is Euro 2020, this soccer tournament in Europe. So if you watch one player who sustains knee injury and they take him out on stretcher, unable to continue the game, this is most probably cruciate ligament. This means you're not going to see this player again playing in 8 months or 12 months. But if a patient sustains, or if a player sustains a knee injury and he's able to continue the game even for a few minutes, this is probably meniscal injury. Joint line tenderness is the most sensitive physical finding, which means what? A patient sustains twisting injury of the knee, and by examination you press on the joint line and there is no tenderness whatsoever. This means no meniscal tear whatsoever. If there is no tenderness, no meniscal tear. If there is tenderness, it could be meniscal tear and it could be other things too. Therefore, the joint line tenderness is sensitive test. If negative, it excludes. Osteoarthritis also results in joint line tenderness, right? So this does not mean rheumatoid arthritis results in joint line tenderness. So that's why joint line tenderness is sensitive but not specific. Ask the patient to squat. If the patient develops posterior knee pain with squatting, this indicates a possible meniscal tear. The special tests for menisci are Tessely test, McMurray test, Applis test, all of them not as sensitive as the joint line tenderness. All of them have low sensitivity, low specificity, okay? And of course, MRI confirms the diagnosis. Anterior cruciate tear or sprain, the most important knee injury, and I really have to run now. ACL tears commonly occur with contact, non-contact pivoting or twisting injuries of the knee. Popping sensation is often noted, followed by severe pain, because the anterior cruciate is the only ligament of the knee that is intrasynovial inside the cavity. ACL tear commonly produces a bloody knee effusion and tense swelling during the immediate 2 hours following the knee injury. And following the ACL tear, the knee becomes unstable and gives way. That's why they cannot continue the game. In contrast to meniscal injury, an athlete who sustains ACL tear typically cannot return to play the game. Tests for ACL, Lachman test and anterior drawer sign. Posterior cruciate tear or sprain, it follows a blow to the anterior aspect of the bent knee, what we call dashboard injury. Okay, not as serious as anterior cruciate tear. Collateral ligament tear or sprain, this is the least significant. Patients are able to walk but may develop an effusion. Baker cyst, sometimes seen on the popliteal fossa in patients with rheumatoid arthritis. Septic arthritis of the knee joint will result in this picture. Let's see the overall picture, what we have here. Meniscal injury, twisting motion, tenderness at joint line tenderness, and other tests, McMurray or Appli. Now let's conclude this lecture with a discussion of ankles and feet. Again, the bones involved. There is a joint between the tibia and the talus. The talus is one of the bones of the foot. So we call it tibio-talar joint. And there is a subtalar joint, a joint next to that. But the most important thing to know regarding the ankle, the multiple ligaments that are involved in the ankle joint. And one of these ligaments, the anterior talofibular ligament, this is the most commonly involved ligament in ankle sprain. What's the difference between sprain with a P, sprain, and strain with a T. We sprain a ligament. So sprain is a ligament injury, and we strain a muscle. Okay. So strain is a muscle term. Sprain is a ligament term. Injury to a ligament is called sprain. Injury to a muscle is strain. Examination of the ankle, this is by inspection. This is the range of motion, or I mean the palpation for what you might detect by palpation. This is the range of motion, and special maneuvers. This is important. When to do X-ray for the ankle, when to do X-ray for the foot following trauma. Again, very important. I'm going to ask you about. So an ankle X-ray is required only if there is any pain in the malleolar zone. What's the malleoli? The malleoli, the bony projections at the lower end of the tibia. This is the medial malleolus, and the lower end of the fibula, here the lateral malleolus. Okay. So if there is pain in this malleolar zone, above or below the malleoli, and any one of the following findings. Bony tenderness at the lateral malleolar zone. What's the lateral malleolar zone? The lower 6 centimeters of the fibula. Tenderness up over the lower 6 centimeters of the fibula, do X-ray. Tenderness over the lower 6 centimeters of the tibia, X-ray. Inability to walk 4 weight-bearing steps, do X-ray. Okay, so these are the 3 indications of X-ray at the ankle. For the foot, if there is any one of these findings, bone tenderness at the navicular bone. Where is the navicular bone? Actually, this is the navicular bone. So this is a typo. This is point D. So this is the correct, please correct it in the slide. Point D. Bone tenderness at the navicular bone. This is an indication of X-ray of the foot. Bone tenderness at the base of the 5th metatarsal. This is C. Okay. And again, inability to bear weight. This slide is important. Ankle sprain. The most commonly involved joint is the anterior talofibular, the most commonly involved ligament, sorry, to result in this ankle sprain, anterior talofibular ligament. We sprain a ligament. We sprain a ligament. So ankle sprain means what? Ligamentous injury, injury of a ligament. And it is the anterior talofibular ligament that is most commonly involved in ankle sprain. It causes severe pain and it requires time to heal. Ankle arthritis, whether rheumatoid, gouty, or septic arthritis. Achilles tendonitis, inflammation of the tendon of the Achilles at the back of the ankle. And what's a drug? What's an antibiotic that commonly causes this Achilles tendonitis, especially in elderly patients who concomitantly take steroids? It is any quinolone, ciprofloxacin, levofloxacin, moxifloxacin, quinolones. Flat feet, that's a very famous condition, easy one. I'm going to leave it for you to read. Plantar fasciitis. 2 things I want you to know about plantar fasciitis. High heels are innocent regarding the mechanism or regarding the cause of plantar fasciitis. It is not high heels. This is one thing to know. The second thing is the pain is closer to the heel. It's on the sole of foot closer to the heel. Excuse me. Patient report sharp pain and tenderness in the medial plantar portion of the heel. Pain is most severe when first arising from bed. What's the plantar fascia? It's this tough sheet of tissue that stretches or extends along the sole of the foot. It affects women and men equally. Contributing factors, flat feet contributes to it. obesity, sudden weight increase, occupations or hobbies like dancing and running. So dancers, that's common in dancers, requiring prolonged standing, sudden increase in activity level, and poor shoe support. Morton neuroma, again, it's pain on the sole of the foot, but closer to the toes. It's a benign tumor of sensory nerves. This is easy stuff. I'm going to leave it for you to read. Neuropathic ulcer usually surrounded by area of loss of sensation, corn and callus. Again, easy stuff. The grade 2 deformities, different names. The bunion, the most famous, the hallux valgus, and other big toe deformities, claw toe and hammer toe and mallet toe. These are all famous. Ingrown toenail, very, very famous. I guess every one of us had it. So some clinical highlights. This is podagra, which is acute gouty arthritis of the big toe. And I'm gonna keep the spine discussion till next.